Everyone. I am Jennifer Tidy, Associate Dean for Research in the School of Public Health and also Professor of Behavioral and Social Sciences. And I am delighted to present our speaker today, but I want to first say a few words about the COBRI grant that is supporting the Distinguished Visiting Scholar Series that brought Dr. Haney here today. The COBRI grant, we call it our CADRE grant, stands for Center for Addiction Research and Disease Exacerbation. We never remember what the E stands for. COBRI grants are meant to build research infrastructure and support early career scientists, and we're in year 4 of our CADRE COBRI. And it's been a wonderful thing for the school, I think. It's been a great vehicle for starting research in some new and interesting areas, and it's allowed us to bring in some great speakers over the course of the year. And today, I'm delighted to introduce Margaret Haney, who goes by Meg. Meg and I actually went to grad school together in the late 80s, early 90s, which is a long time ago. She is professor of neurobiology and psychiatry at Columbia University Medical Center, where she directs the Cannabis Research Laboratory and co-directs the Substance Use Research Center, which is much like our CAS. Her work focuses on human lab models of cannabis and cocaine use disorders. She looks at positive and negative reinforcing effects of cannabis and cocaine. She looks at cannabis as a potential medication, so medical marijuana, and she also looks at medications for cannabis and cocaine use disorder. She's been supported by NIDA continuously since 1999. She was a recent president of CPDD, and she's a fellow of the ACNP, associate editor for cannabis and cannabinoid research, author on hundreds of publications, of course. So I'm delighted again to introduce
Recording in progress.
Meg Haney.
Well, thank you, Jen. And it's so great to be here and to hear about all the really exciting work you all are doing at Brown. It's really been a delight. All right. Got it. Okay, so I don't really have any conflicts of interest. Everything I talk about today is going to be funded by NIDA. So there are really 4 topics I'd like to discuss. I'm going to start by talking about cannabis and cannabinoids, some definitions. I've got a lot of strong feelings about a lot of things, and I'm trying to condense it as much as I can, but this is where I'm going to be talking about cannabis in general and some of its public health implications. Then I'm going to talk about cannabis use disorder and describe our human laboratory model of developing pharmacotherapies for cannabis use disorder, and then talk about our lead candidate, AEF0117, which I'm really excited about. So just to start with cannabis and cannabinoids, I always start with, I'm hearing a bit of an echo here, the yin and yang. Is cannabis good or bad? It's a terribly polarized drug. It's both. It's a pharmacologically complex plant with constituents that have the potential for producing both medical benefit and misuse. So as Jen mentioned, I've done a lot of work with cocaine and with opioids, but nothing compares to how polarizing cannabis is. And a few years ago, neuropsychopharmacology asked me to have what they call a circumspectives piece, which is where 2 scientists come together and evaluate data. And it's typically 2 scientists that don't necessarily interpret data the same way. So I asked Eden Evans at Harvard, and we looked at, does cannabis exacerbate or ameliorate or cause psychiatric disorders? And we talked about PTSD and psychosis. And it's just a great example, both of us coming in as unbiased as we possibly can be, but our interpretation of these data, we did come together, but we didn't entirely agree. So again, I don't think cannabis is anything rivals cannabis in terms of its polarization. So it's something we all have to be aware of when we're doing the science, because everybody seems to have a bit of an angle with it, despite how hard we try. So just to get to some definitions, so cannabis is a hemp plant and it contains phytocannabinoids. These are the cannabinoids that come from the cannabis plant. There are over 100. But there are also non-cannabinoids, terpenes and flavonoids that give the smell and the color and appear to also contribute to its effects, both the abuse-related effects and the potential therapeutic effects. And that's a whole other science that's getting a lot of attention right now. It's really interesting. So there are over 700 chemovars or strains that vary in their relative concentrations of these cannabinoid and non-cannabinoid components. So obviously, these different chemovars produce different effects, and dispensaries will tell you some bogus scientific rationale as to why they do, which is kind of made up. None of us know why, but clearly they do produce different effects. We just don't understand exactly why. But delta-9 tetrahydrocannabinol is the primary psychoactive component of THC. It's how we define cannabis potency. We're talking about really the delta-9 concentration. The other cannabinoid most well studied is cannabidiol. Still a bit of a mystery. There's still so much we have to learn about cannabidiol. It seems to have some potential therapeutic effects. Really differs from THC in many ways. So as we all know, the potency of cannabis, the delta-9 THC content, is steadily increasing. There's a good market incentive to produce cannabis with higher and higher levels of THC. And cannabidiol rates have stayed pretty steady. This is cannabis that is picked up by the DEA. Obviously, there are ways to get much, much, much higher potency of cannabis. You know, you can use the wax distill it. It can be up to 90% THC. So there's enormous variety in the potency of THC cannabis that we can get. So there are 3 FDA-approved cannabinoids since the 80s. Synthetic THC and a THC analog nabilone have been approved to treat anorexia, nausea, and vomiting. More recently, Epidiolex, which is just purified CBD that comes from the actual plant, has been approved to treat severe childhood epilepsy. Those are the only things that have been approved for this plant. So in addition to the phytocannabinoids, there are the endocannabinoids, and this is a really exciting science. Cannabis is an old drug, but this is a new science relative to what we know about many other drugs of abuse. So it wasn't until the 1990s, I was in graduate school, I remember the day that the cannabinoid receptor was cloned and localized, and it was pretty stunning at the time. I don't think many of us knew that THC bound to this receptor, and it's very ubiquitous. It's one of the most ubiquitous G protein coupled receptors in the brain. And it's localized in every area you would predict once you know the effects of cannabis. So it's very densely concentrated in areas associated with cognition, with movement, with anxiety, with appetite, and with reward circuitry. So this CB1 receptor is omnipresent, and its role in physiological function is still being determined despite the enormous progress we've made in these, over 30 years. There's still so much to be learned. In 1992, the first endogenous cannabinoid was discovered, anandamide. In 1993, the second cannabinoid receptor was cloned and localized. It's primarily localized in the periphery, so I'll be really focusing on the CB1 receptor. The CB2 receptor shows up in the brain under conditions of pathology. That's really where you could see it, but all the effects of THC that we're familiar with are really mediated by the CB1 receptor. In 1994, the cannabinoid antagonists were developed, and that really opens up the science tremendously once you have an antagonist on board. And in 1995, this second cannabinoid was discovered, 2-AG. But in 1995, just personally, this paper from Billy Martin's lab came out showing that you could precipitate THC withdrawal in animals maintained on THC. And this was kind of earth-shattering to us at the time because many of us didn't really think that was such a thing as THC dependence. And I'm going to describe this residential lab that we have. And my mentor at the time, Marion Fishman, was talking to me and my colleague, Sandy Comer, and said, we have to study this in humans. We have the perfect setting to really study cannabis withdrawal, and who wants to do it? And I raised my hand, and it changed the course of my entire life. So, for you young ones out there, say yes when you can. You have no idea what will happen, because from that day forward, I really shifted from cocaine to cannabis in many ways, and really focused on cannabis in our residential lab setting. Excuse me, I have a bit of a cold right now. There's also tremendous interest in harnessing the endocannabinoid system. So anandamide is degraded by fatty acid amide hydrolase, or FA. 2-AG is metabolized by MAG lipase. And preclinical studies show if you inhibit these enzymes and raise endogenous cannabinoid levels, you have behavioral and functional consequences. So reduced anxiety-like behavior, Enhanced fear extinction learning in humans has been demonstrated with these FAAH inhibitors. And then related to cannabis use disorder, Cyril D'Souza has shown that the FAAH inhibition reduces cannabis withdrawal symptoms and has just completed a large multi-site trial looking at FAAH inhibition for the treatment of cannabis use disorder. So we're waiting for the results there because that could be really, really intriguing. But this is a whole giant wave of research that's happening with these compounds. And so you could see, this is a bit of a shameless plug, but it's really a terribly exciting time to study cannabinoids. In the past 25 years, there's been marked understanding in our understanding of endocannabinoids. And we put together this review that really is comprehensive from synapse all the way up to epidemiology. And I feel really strongly that endocannabinoids and phytocannabinoids play a role in any aspect of psychiatry or any area of research that you are in. So this happens to be a pretty good primer, reviews all the way through, the science of cannabis and cannabinoids if any of you have interest in pursuing that further. So in terms of public policy, so California was the first to legalize medical cannabis in 1996, and currently we're in this hodgepodge where each state has a different set of regulations about recreational cannabis use, medical cannabis use, whether it's legal for one or for both. Some states it's illegal entirely, except some have exceptions for cannabidiol. So it's these vast changes in public policy that have very little scientific input. And I do just like to make the point that the legalization of recreational use and medical use are really very different issues and different topics. So legalization of recreational use is totally within the purview of voters to decide. Ideally, there'd be an honest discussion of the risks and benefits for society, and there are clear risks and benefits. I think the majority of Americans are in favor of legalization for recreational use, but ideally, we would have this discussion and vote as a country and make a rule either way. But the legalization of medical use and the voting on this is really, really troublesome to me. So cannabis has escaped the process required of every other prescribed medication, which is randomized, placebo-controlled evidence. Should decisions about what constitutes an efficacious medication be decided by vote? So I live across the Hudson River from New Jersey, and in New Jersey, cannabis is deemed efficacious to treat anxiety and migraines, but not in New York. So that's not really serving anybody. It's not serving patients. It's not a good public health policy to be voting on what is an efficacious medication. So the societal changes really so far exceed placebo-controlled evidence. And patients are often told, well, talk to your doctor about medical cannabis, but doctors have none of the data that guide them for the use of other medications. So the bioavailability of different routes of administration. So you can buy product that you rub on your skin versus, take in a pill form versus inhale in vape form. The bioavailability changes dramatically. We have no idea. I don't know what happens when you rub CBD on your skin. I don't know if it gets into your bloodstream or has any effect at all. I know there's a very strong placebo effect, but these are legitimate, drug development questions that you need to know when you're talking about a medicine. Dose, total unknown. Cannabidiol dose, nobody knows. I happened to write a grant to look at high CBD, low THC to the National Cancer Institute. The majority of cancer patients are using cannabis or cannabinoids in some form, and NCI, to my knowledge, has absolutely not a single study looking at the effects of cannabis and cannabinoids. It's really kind of criminal. But we wrote a grant because there's some great indication that it can be useful. High CBD formulations can be useful to treat chemotherapy-induced neuropathic pain. And both times we got just completely destroyed because dose is a total unknown. So one study was a dose-ranging study. No, it's this circular problem that people are just using these compounds with absolutely no idea. So dose is unknown. We don't know about the differing THC to CBD ratios and that impact. And really at-risk populations. Again, clinicians typically would know to give a medicine differentially to children, to adults, that sort of thing. So none of this is known. We really need randomized placebo-controlled trials. These are almost impossible to do because cannabis is a Schedule I drug. It's an enormous regulatory burden. The little studies I do are so carefully controlled, but what we need are large-scale studies in patient populations. The statewide legalization obviously does not extend to scientific study. And so our current state of affairs, it's really large-scale, it's a for-profit industry, and medical benefit is really what marketers say it is at the moment. And it's a shame because there is clear medical potential to this plant and to its components, but figuring them out is still an enormous job. And the other thing that I think doesn't get a good amount of attention, which is really important, is that medical cannabis use. We talk about it as if it's a dichotomy from recreational use, and they're very, very blurred. It's really a risk for cannabis use disorder because the therapeutic utility of cannabis often is occurring at concentrations that produce intoxication. So many patients don't like that effect, but some do. And for those who do, that could be a risk for developing cannabis use disorder. Most medical cannabis patients are using daily. If you're treating it for pain, you're using it daily. That's a second risk factor. Many who are using it for medical purposes also use it recreationally, and those who do use for both have higher rates of CUD than those who use it just recreationally. And there's some data that cannabis users with chronic pain, for example, have higher rates of cannabis use disorder than without chronic pain. So this is a topic because cannabis use disorder isn't fatal and it doesn't have the consequences of other use disorders. I don't think a lot of people have it at the forefront as a potential risk when you're using it to treat a therapeutic impact. So something I am really excited about that we just recently got funded with my colleague Carolina Rood is to really look at what the impact of cannabis use is on the endocannabinoid system. So we know whether you're using cannabis for medical or therapeutic or both, if you're using it daily, it affects endocannabinoid function. We know it downregulates CB1 receptors. It changes FAAH levels in the brain and in the central nervous system. It affects circulating endocannabinoid levels. And what are the functional consequences? This is clearly a really important system physiologically. What are the consequences of disrupting it with phytocannabinoid use, daily phytocannabinoid use? So we're going to be doing a study looking at inpatient daily use of different chemovars varying in their THC and CBD ratios, and looking at the trajectory for tolerance, for example. So how does, tolerance develops differentially depending on your endpoint. How does tolerance to the abuse-related effects develop in relation to its potential therapeutic effects? And we're really looking at pain. We're looking at a laboratory model of pain. And what happens when you suddenly stop, particularly for pain response? We know there's a clear withdrawal syndrome, but we don't know anything that happens to baseline pain measurements. But if you're manipulating the endocannabinoid system, there's a decent reason to believe that you could be affecting your baseline pain sensitivity. So obviously the goal is to mitigate abuse liability and maintain therapeutic efficacy, but neither clinicians nor patients have the evidence needed to make decisions about any of these factors. Okay, so that's my spiel. Now I'll jump back into cannabis use disorder specifically. So recently, a recent meta-analysis using the DSM-5 criteria came out with 22% of those who use cannabis will develop a cannabis use disorder, and a subset of those individuals will go on to seek treatment. And the reasons for seeking treatment are typically more subtle than, again, for alcohol or for other drugs of abuse. It's people are smoking more than they intend to, they have memory effects, they undergo withdrawal, they have health concerns and are neglecting their responsibilities, but also they're unable to stop or reduce their use. So in many ways, Alan Budney has published on this, it's qualitatively similar to other substance use disorders. There's withdrawal, it's disruptive, the amount of time and money spent to obtain cannabis, and it's persistent. So there's failed attempts to quit or reduce their use. So again, the consequences of CUD are not as severe as they are for other drugs of abuse, but it's significantly distressing to the individual. And there is no efficacious treatment. So the vast majority relapse to regular use, even with evidence-based behavioral treatments. And randomized placebo-controlled pharmacologic trials have largely failed in increasing abstinence rates, although some have shown that cannabinoids given orally can reduce cannabis use. So we really need a variety of treatment options, including medications. And so this is the work I've been doing for many, many years. So this is our residential laboratory. We have 4 bedrooms, a social area, and each bedroom has a little kitchen area. And it's really a translational bridge between preclinical and clinical studies. I came from the preclinical lab like Jen, and I'm not a clinician. I don't do the clinical work, but my colleagues at Columbia do. And so it's a really nice kind of little pathway where in my lab I can look at medication cannabis interactions directly. So people come in, they live with us. We're measuring their behavior around the clock. They're smoking cannabis in the lab. I'm giving them medication. Everybody gets every condition, so active and placebo cannabis, active and placebo medications. And they're non-treatment seeking daily cannabis smokers. Wake and bake all day, 2 to 3 grams a day on average, haven't missed a day in quite a while. And so, from the day is structured, but they wake up and they're doing mood and cognitive tasks throughout the day. Really detailed information on food intake and sleep. Those are really robust behavioral effects of cannabis. And our working hypothesis is that cannabis self-administration is the behavior we want to shift with a medication. We want to see if a medication, we can often do things to drug craving with medication or somewhat ameliorate withdrawal symptoms, but unless you're shifting the key behavior of interest, which is drug taking, that's what I consider the signal I would want to see before recommending a medication move to patients in a clinical trial. And so we have different strategies when thinking of medications development, and one of them is relapse prevention. So we can see if cannabis medication can reduce cannabis withdrawal symptoms and a return to cannabis use following a period of abstinence. So this is a laboratory model. I'm not mimicking the clinical situation, but I'm bringing in these non-treatment seekers and seeing if I can reduce the likelihood that after they've gone through this period of withdrawal that they'll return to cannabis use, or if they do, how much they'll use. So this is our model of relapse. And so, initially back in the 90s when we saw that cannabis withdrawal paper in animals, we did several studies looking at cannabis withdrawal, bringing in these heavy smokers, having them smoke cannabis in the lab, and then switching the active to placebo cannabis, and really tracking all the outcomes and getting a real time course for the different withdrawal symptoms. And so the first thing that happens, and it takes about 24 hours because THC has a long half-life, but the first thing that happens is people stop eating, and that recovers fairly quickly, but their sleep is really disrupted, almost, shortly after abstinence is kicked in. Their sleep is disrupted, and that stays disrupted for quite a while. Very distressing to people. I think cannabis suppresses REM, so they kind of have nightmares. So once cannabis is no longer there, there's this rebound in REM, and they're having nightmares, and that seems to last for quite a while. But sleep is disrupted, and that's really uncomfortable for people. Their mood, they're irritable, they're anxious, they're restless, they're not easy to live with. So these studies are really hard to do because they're in the lab in groups of 4 at a time, and they're not feeling great. And we think that this helps maintain daily cannabis use. So over the years, we've tested a lot of medications relative to placebo. So again, we have people move into the lab on several different occasions, and we're looking at the effects of a lot of medications, really looking to see if we can stabilize mood or reduce anxiety or improve sleep has been the goal. And we've seen, if you're looking at withdrawal symptoms, we've seen just pretty much everything. So some medications worsen withdrawal symptoms. Some treat certain symptoms. So mirtazapine really jumps out at me because it really helps. It's an antidepressant that really helps with sleep. They also aid us out of house and home, but those were the 2 withdrawal symptoms that were treated. But again, my primary outcome measure, which is relapse or self-administration, most medications don't do a lot to that. That's a really hard behavior to shift. But the one that worked beautifully was nabilone, which is, again, a synthetic analog of THC. It's got a really long half-life and long onset and duration of action, so you can give it once in the morning. We tested a couple doses. Mood, all the symptoms of withdrawal were really reduced significantly, and people were not getting intoxicated. It's really got this very slow onset, so they weren't intoxicated. And their self-administration went down. So this medication looked incredibly promising to us, attenuated withdrawal symptoms, few indications of abuse liability. once a day dosing is ideal for drug treatment. You don't want to do much more than that. And so, unfortunately, clearly the gold standard is a randomized controlled clinical trial. We haven't been able to get funding to do that, so we don't know the answer if this actually works, but this has been the star of the show for me for this model of relapse prevention. But, a human laboratory model is only worth its weight if it is predictive. It doesn't matter what you see if it's not really doing anything predictive. And for the most part, the lab has been very consistent in terms of negative trials. So what doesn't work in the lab has also not worked in the clinic, except we did have one false positive, which is, it's a great learning opportunity for us. So this is a figure that Kevin Gray at MUSC has originally designed, and I've played with a bit, but he gets credit for coming up with it. So this is in the field, human laboratory studies that have looked discouraging and encouraging, and then fully powered controlled trials, of which there have not been many, and many of them have been done at Columbia, honestly, with Francis Levin. And so the one false positive we got was this combination of lofexidine and dronabinol. So lofexidine is an alpha-2 receptor agonist hypothesized to reverse the noradrenergic hyperactivity that occurs during cannabis withdrawal. And, in the lab, I do these proof of concept studies, so I'm dosing people frequently. I have a lot of control, and, not at all practical from a clinical perspective, but we gave kind of low doses frequently throughout the day. It can lower blood pressure, so we were really careful to not give it when it did, but, we were able to look at lofexidine 4 times a day. We tested a dose of dronabinol that was higher than we tested before. Again, this is oral THC. We gave that 3 times a day, and then we also looked at the combination because they have different mechanisms of action, so we thought, let's try to really approach this and knock it all out. And so, the figure here, this is showing our model of relapse. So this is the amount of money participants would pay to self-administer cannabis, and they actually had to pay for individual puffs of cannabis. So under placebo conditions, they would spend about $20 per day. THC didn't budge this, or dronabinol. Lofexidine alone did decrease self-administration and the number of puffs self-administered, and the combination did the best at decreasing this behavior. So something at the time I didn't pay a lot of attention to because the participants were not distressed by it, but this is ratings of I feel sedated, and so lofexidine was this is pretty high for me. So the max score is 100, and I typically don't see ratings like this, but lofexidine alone and the combination were sedating. But again, these guys were not treatment seeking. They were in an inpatient setting. They didn't mind feeling a little low energy throughout the day, so that seemed fine to me. The combination also decreased craving and really nicely improved sleep, which is, as I said, a very distressing symptom for the participants. So this was looking pretty promising to us. And so my colleagues did a study, 11-week trial, 156 cannabis-dependent patients. They get lower doses than what I tested of dronabinol and lofexidine, again, to try to make it clinically more palatable. They were dosed for 8 weeks, tapered over 2 weeks. They also got motivational enhancement therapy, and there was no medication effect. So the combination, so this is, again, a high bar. The cannabis treatment trials were requiring, to show efficacy, 3 continuous weeks of abstinence, not lapsing once, but 3 continuous weeks. So that's a very high bar. Nonetheless, the placebo and the dronabinol group, the combination medication group, did not differ. Both about 27 to 29% achieved that goal. Importantly, this was not well tolerated. So they did not achieve even the dose that was proposed in this study, which was much lower than the dose that I used. They had blood pressure problems. They were fatigued. They were sedated and not happy about it because they were out in the real world trying to live their real lives. So obviously, this is where it's a reverse translational approach too. If medications work in principle, we need to model the clinical realities, which were dosing and the tolerability, to have predictive validity. So this is where, I learned my lesson about, really, this combination still might work in theory, but it's not going to work in practice. But an interesting thing in the cannabis field, too, for treatment is non-abstinent outcomes. So the alcohol field has certainly led the way here. And I think NIDA and the FDA are getting more open to other endpoints to determine efficacy. My colleagues, again, this is a statistician, Martina Pavlikova and Francis Levin, went back and looked at the 3 randomized controlled trials that were completed. One tested quetiapine, another one tested dronabinol alone, and then the dronabinol and lefexidine group. And none of these medication trials showed effects on abstinent rates at the end of the study, although all 3 showed a similar temporal pattern in a reduction in categorized cannabis use. So starting at about week 5 of treatment, the odds that participants would shift from being daily users to medium users, 2 to 4 days a week versus 5 to 7 days a week, were significantly higher. So all medications shifted them out of that daily use, and that could be a really important clinical outcome. Christina Breezing, also at Columbia, has shown that a reduced proportion of using days at study end is associated with improved quality of life. So obviously with cannabis, we don't have the same markers that you would with alcohol in terms of seeing really dramatic shifts in health outcome. It's more subtle than that, but in terms of self-reported quality of life, shifting away from that daily all day to just a couple days a week, I think is a potentially important outcome. And certainly we need a lot more work on this, but I am happy that both NIDA and the FDA are willing to talk about this issue now. So defining efficacy for pharmacotherapy for CUD is a work in progress. I think medications deemed non-efficacious because they didn't result in prolonged abstinence may facilitate the transition from daily to more moderate use, which is something that patients overwhelmingly want. A lot of people seeking treatment for their cannabis use disorder are not necessarily interested in stopping entirely. Some are, but many are also just interested in gaining control, reining it in, using less often. So that's something we have to pay attention to, and instead of demanding 3 weeks of continuous abstinence. So now the other approach, other than relapse prevention, is abstinence initiation. Does a medication decrease cannabis's positive subjective effects and reduce cannabis self-administration in non-abstinent individuals? And this, for cannabis, may be a more relevant model because patients don't go in treatment inpatient in the United States very often for cannabis. So they rarely achieve abstinence, so there really is no relapse to prevent. So we have fewer tools, fewer medications to look for an attenuation in cannabis intoxication. We looked at cannabidiol acutely, that did nothing. Naltrexone was really interesting. Naltrexone looked a lot like it does for alcohol. In our study with people maintained on naltrexone, it reduced cannabis intoxication, and it just dampened it down a little bit, I think the way that it might for alcohol as well. But what I'd like to talk about is this pregnenolone analog, AEF0117, which is our lead candidate, and hoping this is going to get published pretty much any day now, knock wood. This came out of the lab of Pierre V. Piazza in Bordeaux. I had done my postdoctoral work in this lab, really with cocaine. So pregnenolone, a steroid hormone, his lab discovered that it binds to a specific intracellular site on the CB1 receptor, distinct from where THC and other CB1 agonists bind. And it acts as a signaling-specific inhibitor of the CB1 receptor. So some of you might be familiar with rimonabant, which was a CB1 antagonist, orthosteric antagonist. It blocks the receptor entirely and just blocks all effects of both phytocannabinoids and endocannabinoids. It just blocks the CB1 receptor, where this is quite different. So, this shows cannabis, this active ingredient, THC, binds to the CB1 receptor, produces intoxication. But, in animals, they found that when THC concentrations are very high, pregnenolone is produced. There's an increased production of pregnenolone, and it binds to this pocket on the CB1 receptor, and they know it's on the CB1 receptor by doing single point mutation studies. And this seems to change the effects of THC pretty profoundly. And so this is showing that, again, THC and endocannabinoids are binding to the CB1 receptor. And when that happens, it sets off a course of intracellular events, cyclic AMP, beta-arrestin 2, phospho-ERK, and these intracellular effects are what produce cannabis's effects. But with pregnenolone on board, cyclic AMP and beta-arrestin 2 still occur. When the THC binds or endocannabinoids bind, you're still getting these signals, but one is blocked, then that's phospho-ERK. And this seems to be the key player in the intoxicating effects of THC. So the problem is pregnenolone is not druggable. It has a very short half-life. It's metabolized to active steroids, and it has poor oral bioavailability. So Pierre V. Piazza formed this company, ALIS Pharma, and developed a non-metabolizable pregnenolone derivative called AEF0117. And they did a series of preclinical studies. And so my lab paired up with ALIS Pharma to eventually get NIDA funding. It's this strategic alliance that pairs pharma and academia. But before they funded us, NIDA wanted to demonstrate in their intramural program that this was actually working. So the first study was in mice, and now mice don't self-administer THC, but they will self-administer another CB1 agonist, WIN. And you could see the acquisition of this self-administration. This is under placebo conditions, and this is a low dose of AEF, and that's the higher dose. So it's attenuating self-administration in mice. In monkeys, Zuzana Justanova has squirrel monkeys who will self-administer THC. So here you see the dose-dependent reduction in THC self-administration. And then there's a model of reinstatement, which is an animal model of relapse, where you give animals a very low dose, animals who have extinguished responding on the THC lever, you give them a low dose of THC, and they'll respond again on this lever. And at very, very low doses, AEF attenuated this behavior as well. It also reduced THC-induced dopamine release in the nucleus accumbens, and really affected a range of other THC behavioral effects. So, changes in food intake and object recognition, social interaction, catalepsy, locomotor activity, prepulse inhibition. So AEF was really attenuating THC's effects on a lot of different behaviors. But again, rimonabant really was very alarming, because rimonabant was being marketed for a while for both, primarily for obesity, but also for there's great interest in tobacco cigarette use. But then people maintained on rimonabant, had suicidal ideation and depression, and it had all sorts of consequences. So it appears that just blocking that CB1 receptor entirely is not going to be a good approach. So rimonabant alone has a lot of negative effects. It does decrease food intake and body weight. That's what it was being tested for. Also increases anxiety and depression-like behavior preclinically. In animals maintained on THC, it precipitates withdrawal, increases glucocorticoid secretion, and AEF had none of these effects when given alone. Also, just in terms of clinical toxicity, again, rimonabant ultimately appears to be a pretty scary drug in a lot of ways. There's all sorts of clinical effects that are quite negative, and none of these are replicated with AEF0117. So this is, again, just a cartoon showing how this looks. So this is agonist binding to the CB1 receptor, and an antagonist like rimonabant just totally blocks all the intracellular effects of an agonist, where, again, AEF just is blocking one of those intracellular signaling events, and this is why we think its tolerability is so much better than rimonabant. So here's the strategic alliance. We were then going to move this to the first-in-human studies. We did the first step in drug development is working with healthy volunteers, starting with single doses, then multiple ascending doses, safe and well tolerated, had a good PK profile, no effects on mood, cognition, or suicidality, no effects on steroids or endocannabinoids. So then we got to move it into my lab, and that was really exciting. I was very nervous about precipitated withdrawal. That's never been shown in humans before. There was never a study with rimonabant in cannabis users. So we were pretty nervous about that. Even though in animals there's no evidence of it, you never know. But we enrolled daily cannabis smokers, and they did 2 5-day phases in the lab. And they'd come in and they would smoke a good amount of cannabis. On one condition, they were maintained on active medication and another placebo within the same individual. And our primary outcome measure was abuse-related subjective effects of cannabis, also cannabis self-administration. And we wanted to test 2 different doses because I mentioned with that reinstatement model in animals, that was effective at a very, very low dose. So we wanted to kind of use a parallel dose in humans as that very low dose. And then the higher dose that affects self-administration, we also mimic. So using a population analysis, we came up with 0.06 milligrams a day. You see how potent this drug is. That's a tiny, tiny dose, just once a day. And the other dose we tested was 1 milligram a day. And so the design was just, again, as I mentioned, about half at the 0.06, half would move in on placebo first, half on active drug first. Move out for 14 days. We hypothesized that would be enough time to wash out, and then just come back in and repeat the whole experiment. And so we enrolled 29 non-treatment seeking cannabis smokers, about 33 years of age. They smoked every day, about 3.3 grams a day, had no major psychiatric disorders, no other problematic drug or alcohol use. Some were tobacco cigarette smokers, but were pretty light. And they were allowed to smoke, I think they were allowed to smoke in this study, in the lab. And so each day they would get their capsule at 9 a.m. At 12:30, when we were predicting the medication was at a good level, we would go through the paced puffing technique. So all 4 participants would sit there and we'd guide them through smoking 2 cannabis cigarettes. And then we did a time course. So we just wanted to see for 2 hours after they all smoked 2 cannabis cigarettes, active, all the classic cannabis effects to see if AEF reduced that. But the really important thing, I was talking to someone this morning about the design was, we have 4 people move in the lab together. They instantly become friends. They're very bonded. Cannabis is a very social drug. And that could be a real confound for me, because if one guy's not getting high, they all might conclude that the cannabis isn't good that day. So I really made a very strong point to emphasize that each individual I could be giving them a range of different cannabis strengths, and each individual could be getting a very different strength. So they all had to pay attention to what they were getting that day. One could be on placebo or one could be on active medication. But the important thing is what they smoked at 12:30 that day was going to be later available for self-administration. So they needed to pay attention to what they got that day to make a decision whether they wanted to use their money to purchase individual puffs later that day. So that seemed to work pretty well. Everyone did kind of follow their own what they experienced at 12:30. So then at 2:30, 4:30, 6:30, and 8:30, they opportunity to purchase up to 6 puffs more of that cannabis that they got at 12:30. So this is just a way to say that a priori we built into our plan the possibility of a sequence by treatment interaction. What it turns out that we were wrong about those 14 days. So there was a tremendous sequence effect. If people got AEF first, everything was different in that second phase. The drug lasted much longer than we thought it was going to. So in essence, we had to just focus on that first dosing period, just look at those who got placebo first, which is those who got AEF first, and really not pay attention to what happened in that second phase because it was completely confounded. The sequence effect was really pretty profound. So in just looking at that first phase, so this is our primary outcome measure, felt a good cannabis effect. So again, I'm not an apologist for night of marijuana, but I can say if you give people enough of not so potent marijuana, the maximum score on I feel a good cannabis effect is 100, and these guys are hovering around 85. So this was a really fun study for me to do compared to my withdrawal study. So they were very happy. This is the low dose, 0.06. This was the higher dose. So we're seeing a nice attenuation and felt a good cannabis effect. The liking of the cigarette also attenuated. Intoxication, just the strange thing was the 0.06 had a larger effect than the one in this for this outcome measure, but in general, it was pretty dose dependent. And so this is just showing what happened in that second phase. So if you're just looking at the group that got placebo first, then came back in and got AEF, you see this very nice attenuation and good cannabis effect. But if they got AEF first and then came back, this is their placebo effects. They come in and they're getting placebo, but they're still having this blunted effect because the medication lasted that long. And we could see this with the pharmacokinetics. So this is, again, placebo first, obviously no medication in their system. They get AEF, and we see this nice increase in medication levels. But here's the placebo group. They're coming in already with medication well on board 2 weeks later. So this is self-administration. These are the number of puffs self-administered. This is time. So as you get closer to bedtime, self-administration increases. This is the low dose. So the high dose also reduced self-administration. So getting back to withdrawal, which again I was very nervous about, I wanted to be sure that we weren't seeing any evidence of precipitated withdrawal, and there really was none. So you look at kind of the classic symptoms would be irritability, anxiety, and I feel miserable, and we didn't see any evidence before or after getting AEF. You know, you'd think about giving naloxone to an opioid-dependent person, instantly you would see a whole series of withdrawal symptoms right away, and there was just no hint of that. We did see some hint of almost spontaneous withdrawal. This was, certain individuals seemed incredibly sensitive to the medication where I'd watch them smoke active cannabis for 5 days in a row, and by the 4th or 5th day, it almost seemed like they were going into a withdrawal, just an absence of a cannabis effect. So it wasn't precipitated, it was more like a spontaneous withdrawal. It just happened in a subset of people who, as the time went on, they started to they were smoking and not feeling anything at all. And it almost seemed like they were going into somewhat of a withdrawal. We saw no effect on sleep, another classic withdrawal symptom, and caloric intake. So there was no hint that we were seeing a reduction in caloric intake, which I would predict with precipitated withdrawal. So just the key takeaways, we're seeing a decrease in both good cannabis effects and cannabis self-administration. It was safe and well tolerated, confirmed by multiple analysis, and our dose guess was pretty comparable between humans and animals. To decrease self-administration, you need that higher dose, but we did see a hint of a few effects at the lower dose as well. And it has long-lasting effects, so a concern would be that there would be safety consequences to a medication that lasts that long. We're seeing no hint of that. We're doing a lot of toxicity testing with the drug now, and there really doesn't seem to be. And practically, it could actually be a benefit for drug treatment because you could miss a couple doses. It looks like it still would be effective. So again, we're just moving this along the FDA pathway, and it's just been an exciting thing to see, really, from in vitro all the way into human studies. And it's now currently in a multi-site trial with Francis Levin again leading it. There's currently enrolling. There's 330 patients is the goal, 3 months of treatment, 9 clinical centers in the United States, and it's testing 3 different doses of AEF once a day. And here we did loosen the criteria for efficacy a little bit. It has to reduce use to less than or equal to 1 day per week, so that's better than 3 weeks of continuous abstinence, but still a pretty high bar. So just to conclude, daily cannabis use, be it medical or recreational or both, can certainly result in cannabis use disorder, and really we need more improved treatment options. In the lab model, we're looking for medication shifts in self-administration as an important signal of potential efficacy, and it's translational. We're very much guided by preclinical data, but also guided by our clinical realities. And Nabilone and AEF are our top contenders, and I hope to have an answer on that latter one fairly soon. So this is the Division of Substance Use Disorders. I'm grateful to NIDA. They always supply our cannabis, and that's the Cannabis Research Laboratory. And that's it. Thank you.
that involve? So obviously this is a drug company, developed their drug.
Right.
Oh, thank you.
Yeah.
And how does that all work? Do you all get in a room and sort of figure out how this is all going to work?
Yeah, no, it's a really good question. You know, NIDA over the past, I don't know, 10 years has really been interested. They're no, yeah, I'm speaking for them. I'm just going to say my opinion seems to be that they're not interested in just theoretical understanding of medications. They want something to move along the FDA pathway, you know, very strongly. And so this mechanism was to show, you pair up a company with an academic center, and they want to see the company pour a lot of money into this project, and NIDA will pour a lot of money into this contract, but they won't do it all. They want the company really as a partner in that. But I mean, the design for the study was really, you know, Pierre V and I sitting in a room together and coming up with the plan. So NIDA did, you know, for the first time in my experience, they said, okay, we like this, but we don't quite trust you yet. Let's give us the med. Let us test it in our in-house. And if we like the results, then we'll fund you to continue it on in humans. So that it worked for them, and then they believed it, and then they funded this. And so it is, I think, one of the rare instances where their strategy actually worked. So Alice has poured a lot of money in, but NIDA has poured a lot of money in. And now, you know, we have a second grant now doing all the other components that the FDA requires, 3 months toxicity and all sorts of other things. But it's been their goal to really use their money to get a medication that's FDA approved. So the strategic alliance, I don't know if it's still a mechanism available, but it did work in this instance. It's hard, yeah, because the company has to give up a little control too, but they get a lot of free stuff out of the deal. Yeah. Carolina, you had a question? Yeah.
Yes, I do. So I see that you created your human laboratory study from a preclinical model.
Yeah.
You mentioned that you created from the statement, and I saw
Yeah.
that it was also tested at NIDA through a statement. One of the difficult things that we have in clinical setting is apply the statement to the human lab study. Maybe I miss it, but do your participants has a period of abstinence before you let them smoke?
Yeah, I mean, that's for our relapse model. Yes, we have them. It's enforced abstinence. They go days without it, so they're pretty uncomfortable. And then I want to see, do they relapse or not? And I make it expensive for them so that I get a lot of variability, and that's what I want. I want it. If I made it cheap or free, they would all self-administer all the time. Why wouldn't they? They're non-treatment seeking cannabis users. So I did a series of tests trying different costs where I can see a lot of variability, and therefore I can see if the medication can shift things. Because it's tricky. If it's too cheap, they'll all smoke all the time, even if the medication's sort of working. But if it's too expensive, nobody will self-administer. So I had to find that sweet spot. I think I did. Yeah. Yeah. But in that second phase with the Alice study, that they were not abstinent, and in fact, they got so high at that 1230 dose, their self-admin was pretty low for most of the afternoon and didn't really kick in until later. So it's all a little bit of a balance there. Yeah. Yeah.
Are there any sex differences?
Yeah, it's a great question, and it's terribly understudied, unfortunately. But my colleague Ziva Cooper, who currently is at UCLA, she used to be at Columbia, she's kind of done retrospective looks back on our research and does see sex differences. And you know, this is preliminary, but the pattern is super interesting, where women seemed to be, even that we matched really carefully for amount of use, because men tend to use more, so we were really careful to be sure that they were all using the same amount, men and women. But nonetheless, in the lab with controlled cannabis administration, women were a little bit more sensitive to the abuse-related effects, so they got a little higher, they liked it more. However, we did pain studies, and men showed this beautiful analgesic effect with smoked cannabis and with oral dronabinol. Women showed nothing in the lab. There was no analgesia. So it's fascinating, because women are certainly going to the clinic looking for medical marijuana for pain. And this is a laboratory measure. It's limited, but the fact that we saw this, really, all of our data looking at analgesic effects of cannabis it's men driving it. Women aren't showing it at all in the lab. So there's so much more we need to do with sex differences for sure. But unfortunately, many people aren't controlling for the amount of use, and the tolerance is going to differ then. So Ziva's study was really careful with that. I think that's an important consideration. We need more though. Yeah. Yes. Hi.
I mean, amazing talk. First of all,
Thank you.
so much. And I wondered about moving from non-treatment seekers to people with cannabis use disorder, start having to implement a psychosocial platform
Yeah.
of some type. And I wondered, is everybody becoming more abstinent or less frequent users over time when you take that step, and then it's just becoming a higher bar for the medication to show an effect, or are you not seeing anyone?
Yeah, no, that's a good point. I don't think the behavioral medication treatment approaches are terribly effective. So, the placebo response is always hovering around 27%. Yeah, but it's not zero, so it is making it a higher bar. But just ethically, we can't not do something for them. But yeah, so it does make it a little harder, but I think if its medication's working, it should certainly exceed that, 27% abstinent. Is that answering your question?
Yeah, I was just sort of wondering, maybe that was a reason why the medication wasn't showing effect. 'Cause
Right.
it was having some effect of the psychosocial.
Right. That being impactful. That could be, but I still would think that it's hardly a ceiling effect, 27%. We should still be able to see a little movement there. Yeah, I really am excited about non-abstinent outcome measures because I really think that we would have a tremendous impact if we can get it. It's just my opinion, but those wake and bake all day guys, that's your worst scenario. Like if you can just shift that to fewer days out of the week or certainly not first thing in the morning, I think that all of that could have a tremendous impact. So I feel like we're being so draconian and throwing out so many medications that could be having an impact, Yeah.
Where did that 3 week come from?
Boy, NIDA, again, I don't talk about NIDA, but no, I think FDA and NIDA, yeah, fierce, because cocaine trials were the same. But it's even harder for cannabis, 3 weeks abstinent. Yeah, it's rough, yeah. Yeah, Carolina? Yeah. Yeah.
So this is the story of nalthamine. I mean, the reason why nalthamine was not approved in the United States because it does not show as an endpoint abstinence for alcohol.
Ah,
Nalthamine is approved in the U.S. in Europe because it's an harm reduction, so it can reduce the drinking. The endpoint is not abstinence.
right. So, but like naltrexone, is it like naltrexone? Nalmefene? What is?
It's a similar mechanism of action.
Yeah.
But what it does, as shows in clinical trials, there was no abstinence. So the endpoints were not met, but the FDA did not.
No, because they accepted naltrexone though. That seems so. Yeah.
Things are changing.
Yeah.
The concept about harm reduction, I think, it's huge, and I think that if you can really shows that even a reduction of few days,
That has importance. Yeah, I agree. Yeah. All right. I think we're out of time here. Thank you guys. Thank you.